Thanks. Because I took the Blueprints course last summer in Bethesda, and it really like from restore to performance, like all that, it makes a lot of sense. And I know it's a general framework that you can kind of like scale to like each individual, but I know like for that first part, it's just like control the pain, get the range of motion, control the swelling, get muscle contraction quality back, and then like as you mentioned, like when you move into the second phase, it's like that body weight competency, and then so on and so on. So I just want to see if there was like any small bit I was missing, because that's like a unique population. I always like wasn't sure if I was missing something with that. Because if they didn't have meniscus repair, then you can do the weight bearing a lot earlier. And I always felt like it's
Yes.
like a smoother transition if they're trying to get back to something more active.
Yeah, and typically if they didn't have the meniscus repair, I'm a huge fan of coaching them up on all of your traditional protocol driven activities that we just talked about, establish competency and understanding early on in the clinic, and that becomes home program. And then you can utilize your time in the clinic to do all of your weight bearing activity and all of your things that require more coaching, more cueing, more supervision. And it doesn't mean that you just no longer do the other activities. You either just save them for later in the session, or you have them show up early and do it, or that becomes their home program and you just accumulate time in other areas. I would say one other thing you may, and this all comes back to the clientele that you're working with, but you could look at things from a more systemic standpoint, maintaining just general fitness, aerobic conditioning levels. Maybe they're doing upper extremity, upper body ergometer. Maybe they're doing rowing where they just have one leg doing the work and the other foot's off to the side. Um, or they could be doing upper body or core related stuff too. Typically, with that, it comes down to risk reward, opportunity cost. How urgent is this? But those are things that I often find myself providing them with home exercise ideas as well. Like, hey, you want to stay active? Keep 5, 10, 15 pound dumbbells, keep some resistance band by your chair. Here's a list of 10 to 15 different upper body things that you can be doing just to maintain sanity, maintain some sort of routine with being active on a daily basis.
Thanks.
Yep. Sally, what you got?
Yeah, so off the ACL stuff, so more of like complications, right? So this is more of a clinical example that I'm actually seeing right now. So I just want to kind of see if you have an ideas. I got a guy about 3 months post-op. He maybe had like 12 visits in that 3 months period. He developed kind of some CRPS symptoms in the foot of that same leg. Was still barely basically just weight bearing it tolerated, but saw him, he was on crutches. He was kind of stuck at 110 degrees flexion. And since I've gotten him full weight bearing and off the crutches, with minimal symptoms in that same foot, but flexion, I feel pretty darn stuck at about 115 degrees. So just kind of your inputs, because I feel like a traditional ACL, if you see them start to finish, you kind of get that bigger picture and you can promote that flexion, that weight bearing. But with a little bit of those complications, I'm just curious kind of what you think about that.
Yeah. So have you seen them since the initial post-op encounter, or did they transition to you at that 3 month mark?
He transitioned to me at that 3 month mark.
Okay. So there is good and bad to those situations. The tricky part is you weren't able to be involved in the early processes. So you always kind of wonder like, oh gosh, if we could have done things a little bit differently, could we have avoided this? Or the other part is maybe it was not able to be avoided. And now you get to come in at that 3 month mark. You're a fresh set of eyes. You're kind of a clean slate for this individual. And it's almost a time to kind of give them a new report card, give them an idea of what they're doing well, what things we need to catch up a little bit on, and almost establish things just from a physical and a mental standpoint of like, hey, we're starting over again. We're not starting over again, but we have a fresh start.
Yeah.
The RPS is tough. It is relative, I don't want to say unpredictable, but it's inconsistent with regards to how everybody's going to present with it. Some do very well with just your traditional desensitization techniques, graded exposure, and you just kind of layer that in to what you're already doing with your traditional post-op rehab. I had an ankle dislocation one time. High school athlete slid into a base, dislocated his ankle. There was fractures, there was ligamentous damage. They had to do a pretty significant reconstructive surgery, and he ended up having CRPS, and it was a battle. It was a lot of up and down. It was not a perfectly linear trajectory with how things went. So we had to kind of keep that in mind. The hardest thing with that case, and this parallels with what you may go through as well, is you need to alter and skew your viewpoint a little bit in regards to how long you stick with a game plan or with an exercise or with kind of like a micro cycle of what you're doing for a 1, 2, or 3 week period. And figure out, like, when do I deviate and change path? When am I not getting the result that I expected I would get? Which, under normal circumstances, you typically have a general sample size of, all right, if I do this flexion based activity, I'm typically going to see something positive happen within the session. I don't know how much it'll stick, but we are going to make an incremental improvement. And over the course of a couple of weeks, we're going to be in a better spot than where we were. The CRPS is going to complicate that, either from a tolerance standpoint or just from the clinical presentation of how they show up that day and what they're capable of doing. So I will caution you to just be flexible and be lenient with yourself in regards to, don't get caught chasing your tail and just deviating all over the place based on how they're presented. In regards to flexion, what is the contralateral limb? Do you know roughly what that can get to?
Yeah, like 125-ish.
Okay.
So he's only like lacking 10 degrees, but it's a pretty stiff end feel. I would say his CRPS symptoms I wouldn't say completely resolved, but his major symptoms have significantly reduced there. So he's kind of been a little bit more stabilized, which is great to get strength training a little bit more. But getting into any kind of closed chain flexion movement is difficult because of that kind of hard
yeah. So the nice thing is you are far enough out at that 3-month mark where you have a little bit more wiggle room in regards to your options for flexion activities. And you're at a point where the thing that I always think of is this something that's either an intra-articular restriction? Is it a fusion or swelling based? Or is it something where we need to be mindful of maybe more soft tissue, and we have, quad, rectus, some of our 2-joint muscles where hip positioning is going to influence that? I typically don't introduce something like a pro knee bend or an extensive quad stretch in a hip extended position until they can comfortably get beyond 90 degrees in supine. And I find that if you have somebody that's hovering at like 60, 70, 80, 90, just with like a traditional supine or seated position, when you put them prone on their stomach and try to have them do a pro knee bend, or you try to do a standing quad stretch, anecdotally, I just get people with a lot of patellofemoral compression, and it just becomes very irritable. So I think you are at a point where you can do flexion-based activities in supine, you can do it seated, you can do it prone, you can do it standing, you can do it open chain, you can do it closed chain. I actually was talking about this with one of our PTs in Frederick today, who had a total knee, and they were trying to find different ways to load into flexion to get more leverage. One of my favorite, and it's a nice self-limiting activity for the patient, is giving them a knee to wall exercise, but doing it at progressive heights. So if you think about it, like a traditional knee to wall, think about trying to get like ankle dorsiflexion as your primary restriction. You're going to get some knee flexion that happens with that. If you've got 115, you're not even going to come close to 115 with your foot on the ground doing a knee to wall. But for early ACLs, I like knee to wall because it promotes weight bearing and it promotes knee flexion at the same time. So you can kind of, knock off 2 checkpoints at the same time with that. Now, what you can do with that knee to wall, though, put it on an aerobic step or put it on a plyo box and make that, the higher you get, they're going to have to flex their knee more just to even get the foot on the box. The other thing that I've found is sometimes having that foot in an elevated position, it and I'm not going to be able to articulate the physics behind it, but we'll just speak in generalities. You're going to be loading the knee at a different angle than when it's on the ground. So for some people, just from a comfort standpoint, with that foot elevated, they're able to, one, get the leverage of their body weight behind it to go into the motion, which that's my biggest pet peeve with like heel slides and a lot of like band or towel or strap based activities is it's like a tug of war of how hard they can pull. And then you're trying to have them pull and relax their leg at the same time. And it just doesn't always go all that well. Um, the other thing that you can do is instead of having their foot flat, you can have their foot angled. So it's more of the arch of the foot on the edge of the plyo box or on the edge of the step. Mm-hmm. We were actually using a windowsill in the clinic today. We have like a pretty, not a windowsill, but it's a ledge next to the window. And that little variation of instead of having them foot flat, but foot on the edge, it was enough for them to get a more comfortable loading pattern. And think about like when the foot's flat and they're going forward, I envision just a little bit more like shearing forces happening through the knee. Whereas if it's foot flat, it's almost like they're doing a leg press, like they're loading into it and coming back. And the nice thing about it, stairwells work really well for this because they can incrementally go up to a higher step to either accommodate the amount of leverage they want or the position that they're on. And you're typically going to have one, if not two railings to hold on to. So they can unweight themselves as much as they want with that as well. Now, an added bonus with that activity, early on, I will do knee to walls with people because it couples very well with the back leg, just getting a good gastroc and posterior leg stretch. And you can couple that with that back leg doing a TKE. So now you get posterior leg, you get weight bearing, you get a TKE for more quad activation, and you're doing something with the contralateral limb that has no limitations at all. So like my issue with TKEs and a lot of early post-op rehab, not just TKEs in general, but anything, I think quad sets, quad activation activities. We have somebody sitting on a table, they just had surgery, they're pain, they're swelling, they see this nasty incision on their leg, they have a hard time getting their quad to contract. And you're basically telling them, hey, stare at your leg, do nothing else, and just try to get that muscle to fire. That's really frustrating to do, and you're not doing it very well. So I think finding activities where you're inadvertently going to have the quad firing, a high plank position, a push-up position, those are all things that require terminal knee extension, but it's a piece of the puzzle. So and I'm not saying take somebody 4 days post-op and have them crank out max effort push-ups, but it may be appropriate, have them go to a countertop, something like belly button or chest height, and have them do push-ups at the countertop and let them feel what a straight leg feels like. And that's also going to be a reduced weight-bearing position because it's bilateral support and they're slightly upper extremity supported as well. So I would say, Sally, just think about almost go into the day with, here are 25 different ways that I know I can achieve knee flexion. All of your traditional PT school activities, any weight training or strength training activity that's going to load a knee into flexion, any other creative way you can think about it, and then start to categorize them. All right, which ones have a common theme of closed chain versus open chain? Which ones have a common positional theme of seated versus standing versus prone versus supine? And typically what I do is I just take my best educated guess of what I think they're going to do well with. And if they're not doing well with it, I scrap it and move on to the next thing. And it's a little bit of guess and check and a little bit of trial and error. But if you have a large menu to choose from, you can typically go from one thing to another pretty quickly. Another activity that I really like for bridging kind of that early phase rehab and some of the struggles that you're having now, put them in front of a plyo box or an aerobic step or whatever you have. And early on, prior to doing step ups, I just have people